To continue chapter 25, we'll pick back up with dengue fever. Dengue fever is transmitted by the same types of mosquitoes that transmit yellow fever, Aedes aegypti and Aedes albopictus. Dengue fever leads to fever, weakness, edema, and severe pain. It kind of goes away, patient feels better, thinks everything's over, and then the fever returns with a bright red rash. There really isn't any treatment for this. It is extremely painful. The nickname for this is breakbone fever because of how painful it is, but it will typically go away on its own. It is a reportable disease in the United States, but we don't really see it much in the United States. In the continental US, we do see it in some of our territories and in people returning from those. So here's a picture of Aedes albopictus. Looks very similar to Aedes aegypti, except it's got this one single line, this white line down its thorax there. Of course, we do have Aedes albopictus here. The ranges for Aedes aegypti and Aedes albopictus are very similar to one another. So this is where we had cases that were reported in 2021, 367 cases, which was really down, less than 50% of the cases that we saw in 2020 at 760. You see, Puerto Rico has really high case rates. Most of these that we see in these other areas were not local transmission. They were from people that had been to an infected area and came back and presented with symptoms. Now, there are different strains of the dengue virus. And if an individual gets infected with, say, strain 1 and recovers and then gets infected with strain 2, this is a hyperimmune response. The inflammatory chemicals basically go haywire. The memory T cells become activated because this is something they remember. They've seen this before, they remember. And this launches an insane attack, causes rupture of blood vessels. That's where it takes the name hemorrhagic fever from. And this has about a 30% mortality rate. So it's very important that, people who have contracted dengue fever, they really take precautions to not contract it again, or they run the risk of developing dengue hemorrhagic fever. Now, chikungunya is a fairly new arbovirus. We had not really ever heard of chikungunya in the United States until about 7, 8, 9 years ago. Again, our Aedes mosquitoes transmit this one as well. Very flu-like, fever, headache, fatigue, nausea, muscle pain. So it's very, very similar to the flu. Some individuals also develop a rash. Lasts a few days to a couple of weeks. We first noticed this in 2013 in the Americas. We had local transmission identified in the Caribbean. And then in 2014, we saw local transmission in Florida. 2015, we had local transmission in Texas. And we haven't had any other local transmission in the states since 2015. We've seen it in the territories, but not in the states. So here you can see the spread of chikungunya. This is in 2007. Jump forward to 2018, it had made its way across to the Americas. Thankfully, Ebola is not really anything we have to worry about here. We did have a scare, about 10 years ago or so, of an individual who came from a country that was experiencing an Ebola outbreak. He landed in Dallas, got sick. There was a little bit of local transmission that took place there. But Ebola is not likely to get established in the United States because we have such good health care here that we can immediately isolate individuals and really control the outbreak. They believe that the first person in an outbreak, the patient zero, as we call them, is infected by an animal, and then it transmits through either direct contact or direct contact with the blood of an individual or any fomites like needles or linens or anything like that. And this is an example of the immune system going haywire. This is when those cytokines are released, which triggers vascular leak. Basically, it starts to trigger leaking of the blood vessels and impairment of clotting. So essentially, a person just starts bleeding. They bleed from every orifice: the eyes, the nose, the mouth, the ears, the rectum, the vagina, and eventually the blood flow is so reduced to the internal organs that a person starts to experience multi-organ failure, shock, and eventually death. There really is no treatment for this, supportive care, clotting factors, giving blood, giving fluid, but the mortality rate's about 50 to 80%, depending on the severity of the outbreak. And we see outbreaks from time to time. There's currently a couple of outbreaks ongoing in Africa right now, fairly small ones. And what they do is, you'll notice the incubation date here is 2 to 21 days. And so if after 42 days, which would be 2 full incubation periods, there are no new cases, then they can declare that that outbreak is over. Fortunately, the last couple of years we've had some outbreaks, but they've been very small. So Ebola virus is a filovirus. You see this kind of curled appearance here. The other really reason why it really won't ever be established in the United States is we don't have as close contact with animals like they do in Africa. And then we don't practice the same type of funeral practices as they do in Africa, where everyone, is touching the body. Our healthcare workers are wearing PPE. Caregivers are taught, to use PPE. So not really going to get to the point where it can really have large scale localized transmission in the United States. Hantavirus is a particularly nasty viral infection that we really haven't known about for that long. This sin nombre, or without name strain, was first recognized in 1993, so less than 30 years ago. We know that it's transmitted by infected rodents, particularly a few different species of mice, and an individual would breathe in aerosolized urine or droppings or saliva or even nesting materials. Typically what happens, where we really see a lot of transmission of hantavirus, is out west, as you'll see on the map. But what happens is an individual, they go into a barn and they decide to clean up their barn or their storage building, and they start sweeping, and they come across a rat's nest or a mouse nest, and they're sweeping that up, and the droppings and the nesting materials are going to become aerosolized. They're going to breathe that in, and it may take as long as 5 weeks before symptoms start to appear. They start out with kind of flu-like symptoms, but then a few days after the initial phase, they start to have pulmonary edema. So they get swelling in their lungs, and it's pretty severe pneumonia and can lead to shock. Really no treatment. There's no cure. There's no vaccine. We really don't know a lot about it. You see their pathogenesis is unclear. We don't really know how it does what it does. And so the mortality rate for hantavirus can be up to 50%. In the United States, there are 4 major vectors of hantavirus pulmonary syndrome: the deer mouse, the cotton rat, the rice rat, and the white-footed mouse. And we have all of those in our area, but fortunately, we don't really see very many cases. In fact, this is through 2019. So from 1993 through 2019, these are the cumulative number of cases. So you can see the majority of cases occur out west, okay, the Four Corners region, 1 case. So in that, what is that, 26 years that we've been reporting hantavirus, Arkansas has experienced 1 case. And that's not to say that that case actually occurred here. It could have been an individual who, went and traveled to New Mexico and then came back home and was diagnosed, since it does have that long incubation period. Human immunodeficiency syndrome, HIV. The human immunodeficiency virus affects the CD4 T cells, which are a particular type of T cells that help to activate the immune system. And when these cells are destroyed, then basically it decimates the entire immune system. At this point, we do not believe it is possible to eliminate HIV from a patient's body. Now, there have been reports of individuals who have been declared HIV-free, have been declared cured, but it's thought that HIV will continue to hide. And even if there are no more viral particles, because it is a retrovirus, it's possible that its genetic material is still within the T cells. So the first stage of an HIV infection is the acute phase. And about 2 to 4 weeks after infection, some individuals experience kind of a flu-like illness. This may last for a few weeks, goes away, and then no other symptoms occur. And then the virus goes latent. They're still active, okay? They're still HIV positive, but the HIV reproduces at very low levels, and the individual is probably not going to experience any symptoms of the illness. If they're taking, if they're not taking any medication, the stage may last 10, 12 years. If they are taking medication, so if they have been diagnosed with HIV and they are taking antiretroviral therapy, this may last 20, 30 years or more. Near the end of the latent stage, this is when the virus starts to become more active and the CD4 T cell starts to decrease and the individual becomes immunocompromised and starts picking up, these relatively mild infections that other healthy individuals would not contract. And then we get to AIDS. Patients are diagnosed with AIDS when their CD4 T cell count drops below 200 cells per microliter, or when they start to develop this kind of cluster of these opportunistic infections. Patients with AIDS have a high viral load, they're highly infectious, and without treatment, they survive about 3 years. So now switching over to our protozoans, we have malaria, which is caused by Plasmodium, and there are 4 different species, Vivax, Ovale, Malaria, and Falciparum, that cause malaria. And this one is spread through Anopheles mosquitoes. So we've looked at the Aedes mosquitoes that spread yellow fever and dengue fever. And now the Anopheles mosquitoes spread malaria. Now, malaria is a disease that causes chills and fever in a cyclical pattern every 48 to 72 hours, depending on which species the individual is infected with. So here's an Anopheles mosquito. This is not a great picture. There's a better one in your lab where I really talk about what distinguishes the Anopheles from the Aedes and also Culex mosquitoes, which we'll get to in the next chapter. So here are the ranges of the different Anopheles species throughout the world. In our area, the most likely species that we'll have here is Anopheles quadrimaculatus, but you can see they're distributed all over the world. So malaria has a very complicated life cycle, okay, very complicated. So what happens, we're going to start outside the human first. We're going to look at these mosquito stages first. So mosquitoes, of course, are biological vectors. And so there is what we call the sporogonic cycle that occurs within the mosquito. And then in the human, we have the exoerythrocytic, or outside the red blood cell cycle. This is happening in the liver. And then we have the erythrocytic cycle happening within the red blood cells. So here's what happens. Mosquito takes a blood meal. It injects a particular part of the life cycle called the sporozoite, okay? The sporozoite makes its way to the liver cell and infects a liver cell and forms what is called a schizont. The schizont is full of these little immature protozoans. Eventually that cell is going to get so full of schizonts, or it's going to get so full of these immature forms that it ruptures, okay? And so now all of these little immature forms of the protozoan are going to be released into the bloodstream. They're going to find red blood cells, okay? And they're going to infect the red blood cells. And at this point, they become trophozoites. So remember, trophozoites are the active, kind of the adult stage, the feeding stage, actively growing stage of a protozoan. So we have mature trophozoites, okay? They start to replicate, essentially, form another schizont. The schizont ruptures, and then we repeat this cycle over and over again. And this accounts for the cycle of infection. This will happen either every 48 to 72 hours. And so when the schizont ruptures, that's when the individual is going to start to feel symptoms again. Okay. Now, there's another part of this. Okay. Some of the trophozoites form gametocytes. Okay. Or the immature form. Okay. These then are picked up when a mosquito takes a blood meal. So when they take the blood meal, they ingest the gametocytes. Okay. These basically develop into an oocyst that ruptures to release the sporozoites, and now we're back into the human. So when a mosquito takes a blood meal, it injects saliva, and these sporozoites are going to be in its saliva. And that's how an individual becomes infected. And so here are some different images. This would be like the ring form of the trophozoite here. This would be a schizont, okay? And then here would be a ruptured schizont. So all of these little immature forms are going to find other red blood cells to infect. So malaria was a huge problem in the United States back in the 17, 18, and even early 1900s. And this was a cartoon that was drawn depicting this individual who's wearing, you know, a coat and hat and shivering. It's showing these chills, and it says malaria is a fashionable disease that, you know, they didn't really know. They had no idea where it was coming from. So in 1882, you see a wide swath of the United States was what they called malarious, infected with malaria. And, you know, once we realized that it was caused by mosquitoes, we started to, you know, treat for mosquitoes. We started to learn how to keep mosquitoes from, you know, getting into areas. And so by 1912, we had reduced A lot of that due to, mosquito eradication efforts. And then by the time 1932 rolls around, we've just got a few pockets left, huge area here in the Mississippi Delta, some swampy area of Georgia and South Carolina and Florida there. So we were really basically able to, through mosquito eradication programs, to get rid of all of those infected Anopheles mosquitoes. Now, mosquitoes are still here. It's possible that the protozoan, the parasite, is still here, but we don't see local transmission of malaria. We do still have people that contract malaria in other countries and bring it back here, but those are very few and far between. So we don't have local transmission of malaria here. So another protozoan here, Toxoplasma gondii, causes toxoplasmosis. This is spread by cats. It is in their fecal matter. And most people who are infected are asymptomatic. They, especially if we're looking at healthy individuals, they may never know that they're infected. But it does pose a risk during pregnancy because the tachyzoites, one of the immature forms of the protozoan, can cross the placenta and cause harm to the developing fetus. So, don't breathe in when you're changing the litter box. Wear a mask, wear gloves, wash your hands, and pregnant women really shouldn't change the litter box. Now, cats aren't the only animals that can spread toxoplasmosis, but we're most associated with cats. We're not around birds and mice and pigs and sheep as much, but we are around cats. So next we have Chagas disease caused by Trypanosoma cruzi, and we'll see its cousin in the next chapter that causes African sleeping sickness. Chagas disease is carried by the triatomid bugs, sometimes called kissing bugs or assassin bugs. As the triatomid bug is taking a blood meal, it defecates, and the saliva triggers an immune or an inflammatory response, and we itch. And as we scratch, we're basically scratching that feces into the wound, and that's where the point of infection occurs. Incubation time within a couple of days. And when I was doing some research on this, the CDC website says that a person immediately starts showing symptoms. That seems a little implausible. In the United States, possums and armadillos are primary reservoirs, and you see there Arkansas, Arizona, Louisiana, Mississippi, Tennessee, and Texas all conduct surveillance for Chagas disease as of December of 2017. This isn't something that we ever had to worry about. We had some of these triatomid bugs here, but we saw no local transmission, and now we do see local transmission. So we have started surveilling for Chagas disease. The acute stage is characterized by chagomas, which are swellings at the sites of the bites. And then it enters into this stage kind of like a flu-like illness, fever, swollen lymph nodes, and then it can infect the heart, it can infect the spleen, infect the esophagus. Then the person goes into a chronic stage. Then they come back to a symptomatic stage by congestive heart failure, because what happens is the trypanosomes are going to create this particular form called the amastigotes, and they form these cysts within the heart tissue. So here's a red blood cell smear showing the appearance of these trypanosomes, these little wriggly structures here. This is the life cycle. So triatomid bugs are biological vectors. This is Romania sign. This is an example of a trachoma. So you get this intense swelling. So the bite would have been somewhere here around the eye. The reason why they got the name kissing bugs is because they like to bite on the face. I'm not really sure why, but they bite around the mouth, around the nose, and then, of course, this individual around the eye here. Leishmaniasis, again, something that we didn't really have to worry about 20, 30 years ago. Leishmaniasis is transmitted by the bite of a sandfly, either in the genus Phlebotomus or Leishmania. It is an obligate intracellular parasite. It gets into the macrophages, which are the cells that are designed to ingest pathogens, but it can survive within those and reproduce. There are 3 different forms, and the cutaneous is the one that we see most common in the United States. There are sores that form at the site of the bite. They can become large ulcers, but they will typically resolve on their own. Visceral Leishmaniasis may take months or years to develop. This is the more fatal kind of Leishmaniasis. You see there, it can infect the lymph nodes, the liver, the spleen. It really becomes a disease of the lymphatic system. And then mucosal is a less common form that is similar to the cutaneous form, but it's in the mucous membrane. So it's actually within the mouth, within the nose, or within the throat. Here's a picture of a sandfly. These are really tiny. Here's a picture of a sandfly next to a mosquito. So you can see these are really, really tiny, about the size of midges. And again, this really isn't something that we had to worry about. We first noticed it in the United States in combat veterans who are returning from the Middle East because they have a lot of sandflies there. And so we were seeing these, infected veterans. And then we noticed that there is some localized transmission that does occur in the southern United States. So that brings us to the end of our cardiovascular and lymphatic diseases.